Hi, today we are bringing a very important discussion about women's health. There are very many issues affecting a woman, and by the way, issues affecting women do not affect women alone, they affect men in Indonesia because a man, a woman are two people who are created to live together. But you know what? My name is Afanatiko, and today we are at Sali International Hospital in Dar es Salaam, Tanzania. And I bring Dr. Shabnam, who is going to discuss very important issues surrounding women's health. Welcome, Dr. Shabnam.
Thank you, Arthur. How are you doing?
Thanks. How are you?
I'm good.
Glad to be here.
Thank you.
Okay, introduce yourself to our
Hello,
viewer.
everybody. It's Dr. Shabnam here, Dr. Shabnam Mukaddam, obstetrician and gynecologist at Sali International Hospital, dealing mostly with women and their
Wow.
problems.
Wow, that's wonderful.
Thank you.
For how long have you been an obstetrician?
For about, since graduations, you can say 3 years.
Oh, 3 years.
Yeah.
What inspired you to become an obstetrician? You should have done something else maybe, but you ended up here.
Basically, obs and gyn has always been my forte. I'm happy when I'm with my women and when I am actually making that transition beautiful for women. When you get women coming in expecting you to make sure that their pregnancy goes smooth, that their transition into motherhood or into parenthood, I would say, goes amazing. So that is where we step in, and that is where Sali International Hospital steps in.
Okay.
But not only that, it also pertains to a lot of other problems that women come in with. Basically, it's a broad, vast thing that we're dealing with here. So from helping women get pregnant, from helping women deliver, from helping women deal with their period irregularities, from helping women deal with pelvic pain and a lot of other conditions.
Okay, it's quite a lot. Now, in your period of expertise,
Yes.
what are the main issues that women present when they come to Sali International? Yeah.
From the time that I have been at this hospital, I would say, we get a lot of cases that come with pregnancy itself, just a normal pregnancy or a high-risk pregnancy, where we ensure that the woman goes through the transition smoothly and the delivery process goes well for them. But together with the pregnancy, we also see a lot of other cases. Basically something like infertility, where women come in looking for a child for many years of struggle. We see women coming in with endometriosis. We see women coming in with polycystic ovarian syndrome. This is something that I encounter almost every day.
Okay.
Yes. We see women coming in with a lot of other problems like fibroids, adenomyosis, and a lot, and henceforth.
Okay, talking of infertility, I understand it's almost an increasing case, not only in Africa, I think, but globally.
Yes, it is.
Yeah, so if we are to zero on Africa and specifically in Tanzania, what are those major causes of infertility? Let's shed light on them.
Infertility is something that has been a very big problem at the moment. A lot of women come in, they struggle a lot. They go to different hospitals with the same struggle for many years. If you take in the statistics worldwide, infertility is affecting about 11 to 17% of women in the world. That's a big number. That's a very big number. And from those percent, there is about 30% coming from the women, causative factors coming from women, 30% coming from the man.
So it is the same, the cause in men and women are the same percentage.
It's actually equal. So that's where the problem comes in, because majority of the time we see that women come in alone without the partner.
To the hospital.
Yes.
Okay.
So you see her struggling alone because apparently I think it's a stigma topic to say that a man has problems in impregnating a woman. The remaining 30% is basically both-sided causes. So both of them could be having an issue here and there. And well, there are those 10% where everything seems to be normal and it's just unknown. And basically, we don't know what is causing the infertility.
It's sensitive, scary, and stigmatizing.
The stigma is, I think, one of the most leading problems here in Tanzania.
Okay, why, specifically, why do men fear coming with women? Is it lack of information? Is it
It's
what explains
I
that?
think it's the educative system here, the
Mm.
education, the level of education. Of course, right now I am seeing a difference from what we were 5 to 10 years ago, and from where we are heading off to right now. Because we are educating, the social media. There is people are studying nowadays. They know there is Google, Mr. Famous Dr. Google. There is a lot of seminars that doctors do. So I think that is spreading information to basically everybody that having a problem is not something to be fearful of. You should come forth. The support that you can give your wife through this journey or your partner through this journey is very important.
Okay, now what could be cause infertility, affects both men and women, just like
Yes.
you said, in equal measure.
Yes.
So when does a couple know that they are actually infertile? When does someone realize there is a problem?
Ideally, when you start planning for a pregnancy, majority of them don't come to the hospitals, so they try to plan out. So we believe giving them a 1 year span without any use of any contraceptives, and to have adequate amount of intercourse per week.
What's adequate amount of
at least
intercourse?
3 times a week,
Okay.
but especially targeted on those fertile days, the fertile window, from when we expect that the woman might be ovulating. Those days are very important. So if that continues on for a period of 1 year with no outcome, then we advise that please visit the nearest health facility so that help can be provided to such women and such couple.
Okay, now coming to the hospital, the couple is to come. Before we come to the hospital, what are those major causes of infertility in first men and then women?
A lot of times in men, we notice a reduction in the sperm count, or basically no sperm at all, something known as azoospermia, where we don't have sperms at all, or reduction in amount of sperm quality and quantity, so oligospermia. So when I say reduction in quality and quantity, so there is the number of sperms that are supposed to be basically in a sample of ejaculate. Okay, so if there is a reduction of that, the quantity, that means you're already reducing your chance of pregnancy by having low number of sperms. Now, from those low number of sperms, there are some sperms that are not viable to bring a pregnancy, so the quality is altered, further reducing your chance of pregnancy. Most of the time, sometimes it could be a tumor in the testicles somewhere that prevents the sperm from reaching the semen. Yeah, so that is where we notice where there is no sperm at all in our ejaculate. Or sometimes you just like that.
Just like that. So in men, it's majorly sperm factor. Could you talk about the causes of maybe low sperm count or no sperm at all?
Like I said, tumors, lifestyle. Right now, if we look at our diet, a lot of carbs everywhere. Sugar, carbs, alcohol, smoking, lack of movement, lack of exercise, all that actually affects the body. The oil we take, basically the best oil for our health is olive oil or something along the lines.
But we are not taking it.
But we're not, So
because we don't know or we don't care.
I think it's always for some budget. You see, we have low income people in the country, so it's a budget. Sometimes it's the education itself. They don't know, they're not aware. So what you need to be taking, the high protein diet, that is missing most of the times. So our staple food itself is what? Ugali and rice and all that. So that's like a lot of carbs. So what people end up doing, they end up just satisfying their tummy with the carb diet,
and that's
not knowing that a balanced meal is very important.
Okay, interesting. Looking at women, what could you talk about the causes?
Women,
infertility.
There are various causes. Mentioning a few, we could have myomas, the fibroids, which are basic benign tumors in the ovaries, in the uterus. Then we have something very common, polycystic ovarian syndrome. This is one of the, from what I have noticed, my stay here at Salih International Hospital, is one I see people every day basically coming with polycystic.
Presenting with PCOS, and then what else?
Then we have tubal blockages. So that happens, majority of the time it's an infection that travels through the vaginal area, up to the uterus into the tubes, causing adhesions.
An infection
And
that
blockages.
goes untreated.
Yes, untreated infection.
Okay, that
Yeah?
is important.
So
Okay.
that goes and blocks the tubes,
Mm.
causes adhesions, causes hydrosalpinx, the blockage, the water blockage at the tube.
Mm.
So all that. Because if the tubes are blocked, you cannot expect the egg and the sperm to meet, making fertilization possible.
Okay, I think that point of PCOS and infection are two important
Yes.
factors in infertility in women.
Yes.
Can we shed light, number one, on PCOS and then later on tubal factor?
Yeah. So
what is PCOS?
Basically, you see a lot of women say that they are polycystic. We hear a lot of women saying, Mimi, I have PCOS. Daktari, Mimi na uvimbe wa mayai. So many people don't know. They're not given the education of what it is. It's basically a multidisciplinary thing. You see? So it is characterized by a variable symptoms. Basically, ovulation dysfunction, hyperandrogenism. And we see peripheral cysts that are noticed on the ovaries. You see? So when I say peripheral cyst, we have the ovaries. So multiple cysts are seen at the edges of the ovaries on the periphery. At least 10 to 12 or more than that, making the volume for about 12 mils. That is
on the ovary.
On the ovary, yes.
Okay.
Okay. So when I talk about hyperandrogenism, I know it's a medical term. So if I say it in a lay language, where we have a lot of hair growth on the chin area
of the woman.
So yes, unwanted hair growth in areas that are really not required. Yes.
I've seen women with some beards, hairy hands.
Or on the chest area, on the abdominal area, excessive hair growth, you see. Some women suffer from acne. So a lot of acne on this side and on the forehead. Yeah, so PCOS comes in those ways. Of course, the causes are unknown, but there are risk factors. Yeah,
the risk factors in infertility.
Yeah, the risk factors that cause PCOS, which then lead to the infertility. So risk factors, like I said, lifestyle. The diet is terrible. No movement, no exercise, which leads to obesity. Obesity being one of the major risk factors for PCOS. If I tell you the statistics for PCOS worldwide, it is more than 116 million women affected all over the world.
Globally.
Majority of them being reproductive age.
Oh yeah, because I was about to ask you what's the age bracket of women who are affected by PCOS.
So reproductive age.
And what do you mean by
25, 35?
25, 35. Okay, we are going to come to the management options. And then you talked of the tubal factor in infertility. Shed more light on that.
Majority of the time, it is an infection, a bacterial infection, basically mentioning. Okay, so when your immunity is down, or when you have unprotected sexual intercourse with someone who basically is carrying that bacteria, you get infected and it travels and goes and blocks the tubes. It's basically a slow process. It does not happen immediately, but if left untreated, that can cause blockages.
So when the tubes are blocked, what happens now?
What happens when we have a blocked, unfortunately I don't have a picture to show you, but we have the uterus and then we have the tubes on the sides. So when we have a blocked tube, the ovaries come on the edges here. So during the time of ovulation, the egg is supposed to be released there on each side every month. They alternate, yeah? So if we have blocked tubes, the egg travels through the tubes where the sperm is supposed to go and meet and fertilize. Now, if there is a blockage, the sperm cannot go fertilize
the egg.
Okay. So, no baby.
In other words, no baby naturally.
Yes, naturally it's very difficult. And this one, majority of the times, it's diagnosed by doing a test called hysterosalpingography, whereby a woman is given a dye vaginally. A dye is inserted vaginally and multiple X-ray pictures are taken to see how the dye spreads through the uterus into the tubes and then spillage. So when we follow with the dye and we notice that there is no spillage, we know that that tube has a problem.
It's blocked.
Yes, it's blocked.
Okay, is blockage same as hydrosalpinx, or they are two different things?
Now blockage is basically a broad term.
Mm.
Hydrosalpinx basically does cause blockage.
Oh,
Yes.
okay. That's important because some people confuse the two.
Yes.
Okay, you talked of fibroids.
Yes.
How do you link fibroids to infertility? And what are the causes of fibroids in women?
Basically, again, fibroids causes are, we can't say causes per se, but maybe risk factors that are involved. Yeah. Majority of the time, fibroids are genetic. They're familial. They're inherited. So you'll see most of the time it's a first degree relative. If your mother or your sister has that, you're at a high risk of getting that. Okay. Sometimes it is also noted that if you had a previous fibroid and you had it removed, chances of it recurring again is high. Okay. Thirdly, nulliparity, delay in getting pregnant.
Oh.
Yes, it is also a risk factor.
How?
It has been noticed that is how it works.
Okay.
Uterus is empty for a long period of time and benign tumor forms.
So
and it has been actually noted that African women have a higher chance of also getting fibroid. Is it because they delay to give birth, or is it because of those other factors? It's about those other factors. Most of the times it's the genetic and hereditary factors, and research has been shown that African women have a higher risk of getting fibroids. Okay. Ethnicity, basically.
Okay. So just link fibroids to infertility. Do fibroids cause infertility or not?
Fibroids can cause infertility if they're big. Okay. Now fibroids can grow. We see the uterus has layers, yeah. So the fibroids can grow either on the outer layer, on the middle layer, or on the inner layer, where the fetus is supposed to go and implant. So if we have a very big fibroid inside, it prevents sometimes for the pregnancy to go and implant. Okay. And if by chance a pregnancy did implant, again chances of miscarriage was also high. Yes. So it all depends on the size and the quantity of the fibers. If you have multiple fibers, getting pregnant is very difficult. But not only does it increase chance of miscarriages, it also increases your chance of prematurity, premature labor, premature baby, pain, severe pain. There's something called as red degeneration, where the fibroid undergoes changes during pregnancy, and it causes terrible pain. Yeah, because I was about to ask, how can someone know before coming to the hospital that actually I could be having fibroids? Yes, that is where now what we recommend as doctors, that when you are trying to plan for family, or like increasing your family, please visit your doctor. Not only for making a baseline, investigation on you to make sure that you're doing okay and that you don't have any underlying conditions with you, but also to educate you more on the use of folic acid, on the use of, on what your fertile days are, on giving you basic necessary information. So it's a visit to a doctor prior to getting pregnant is very important. Okay, still speaking infertility, I understand sometimes a couple may go to the hospital, the man tests, everything is okay. Yes. A woman, everything is okay. What we call unexplained infertility. The 10% that I referred to actually comes there now. The 10% of cause of infertility is unknown. There is literally no causative factor as to why the woman is not getting pregnant when everything else is okay. Now, when we have such cases, majority of the times we recommend there are drugs that can be used, the ovulation induction drugs, whereby you're given tablets and a follow-up is done to make sure that the eggs are ovulating on time. And we try that way. If nothing works out that way, we usually don't recommend using those drugs for a long period of time because you're depleting your follicle count. Oh, okay. What those drugs do, they cause your eggs the ovaries to release multiple. Stimulate many. Yeah. Okay. So when they stimulate multiple follicles, that means you will be releasing multiple follicles. So instead of releasing one egg, you are releasing many eggs. So using it for more than 6 cycles is usually not recommended. Okay, wonderful. We are going for a short break, and when we return, we are going to look into management options
for both male and female infertility. See you in a few. Welcome back to the show. We are still here with Dr. Shabnam, trying to explain issues surrounding women's health, and we started with infertility. Now we are looking into the management options, because if infertility is a disease that affects both male and female reproductive systems, it means then there are solutions. Isn't it, Dr. Shabnam?
Definitely. Nowadays, science has gone way beyond. When it comes to such couples where infertility kicks in and
Yes.
they're looking for options and they have tried, it's not like they've not tried in drugs, they've tried several options, but nothing seems to work out. Then we offer something known as IUI, we offer something known as IVF. When I say IUI, it is insemination of the sperms. So basically what happens, when the woman has been followed up and we know it's time for her ovulation, sperms are taken via a special tube that we have, and they are helped to be inserted inside the uterus to reduce the distance of the swimming so that they are closer to the eggs and ovulation can take place.
How do you get there? Like a couple walks in,
Now, a
to
couple
your
walks in,
consultation
yeah.
room, and
A couple
how does
walks
it happen?
in. Ideally, we talk to them to find out what exactly they have been doing. Basically, a very good history is taken as to how they've been trying, how many times they've been trying, how long they've been trying for, what other hospitals did they visit for, and if they did, was there any treatment that was done? Was there any test that was done? Basically, all that. Okay. Examination of the woman is done basically on the general. Okay.
What do you examine on the woman?
We'll check the abdomen if for any masses. We check her cervix. We check the uterine size and all that. Something known as bimanual examination. Okay. But after that, we have to order a hormonal panel when it comes to the woman. So basically, these are a range of different tests that we do via the blood. We check for hormones such as follicle stimulating hormone, luteinizing hormone, prolactin, thyroid, because thyroid does affect infertility as well. Okay. We check for estradiol and anti-Mullerian hormone. Okay. Basically, anti-Mullerian hormone will give us the ovarian reserve if we have enough eggs, and if what response of that egg would be to if they opt for IVF. You see. We also do a transvaginal scan or a pelvic scan on women to rule out other causes like endometriosis, like fibroids or ovarian cysts, and so forth. Okay.
And then on the man?
Now, on the man, we usually do a testosterone levels on him. These are basically the androgens, the male hormone, yeah? And we also ask him to do a semen analysis. Of course, the semen analysis has some conditions that need to be fulfilled. Okay. Yeah. So basically, those conditions are explained to him, and when need be, when those conditions are satisfied, he comes in, drops in a sample, and we carry out the semen analysis. Basically, the results don't even take long, 2 hours or so.
So by semen analysis, what do you mean?
The ejaculate. He has to ejaculate in a container, which then is taken to the laboratory. Over there, they check for the different things are checked for the sperm count, the fructose level, the acid level, the pH, all that is checked usually. Sometimes even infection is noted, and then they are treated accordingly. Of course, another very important test again is for the tubes for the woman, where they do the HSG, and the tubes are also checked. So once we have all that and we have found out the cause for that, if it can be treated fair enough, if not, options are available for such a couple. For something like oligospermia or a tubal block, options such as, if you have a tubal block, we highly recommend IVF, in vitro fertilization, because doing a surgery to open that tube is basically, she will end up with the same thing, adhesions, again a blocked tube. pregnancy, chances are very high.
Mm.
So for her to not, go through that stress again, we basically just advise her to go for in vitro fertilization.
And what's that? What's IVF?
Now, IVF is basically a procedure aided to help couples get pregnant.
Okay.
Okay. So individualized stimulation of the ovaries are done, of the follicles are done. Give hormone boosters that will stimulate follicles. They have their own cycle. Okay, basically, I will not get into the nitty-gritty. Hormones that are her uterus for the day the embryo transplant is done, and also for the follicles a transvaginal scan. So when we know that egg retrieval under an ultrasound guidance, okay, the egg retrieval is done. The man is supposed to give us a sample of which sperms are taken. The ones that we know that are mobile and are like proper looking, they're taken. Now, an embryo's fertilization is done where the sperm is injected into the egg.
Under which arrangement? Like here on table?
They have their own lab. This is a specifically equipped, separated completely entity from the entire thing. So this is basically taken very seriously.
In the laboratory?
Yes,
dedicated for IVF
specifically
treatment.
for IVF matters.
Okay.
Yes. So once that is done, and once we know that the woman is, the uterus is of the size that is required, the embryo transfer is done. Of which, some few days, she will still be continually taking the hormone boosters to make sure that, we get a positive outcome. After about 10 days or so, a scan is done to check for the pregnancy. Yes. And of course, not forgetting to mention that the lab workups for pregnancy test is also done.
Oh, quite a journey.
It is, and it is quite stressful. That's why we usually do a very close follow-up with our women, because this is mentally exhausting for them as well. Imagine coming from a struggle of not being able to conceive for a period of 6 years, 10 years. Some women even come menopausal and are still looking for a child. So that stress compared to this stress of continuous doing tests, follow-up, it's quite
troublesome. I see. Okay, also you talked of fibroids.
Yes.
How do you manage fibroids?
Now, when fibroids come to a point of where it interferes with, conceiving or causing recurrent miscarriages, then it definitely needs to be worked upon. Okay. Basically, surgery is the way of option, the way of treatment for fibroids. So we have laparoscopic myomectomy. Okay. Then we have open myomectomy. Okay. Laparoscopic myomectomy are done for smaller fibroids. Okay. And we have the open, with laparoscopy basically is where we do just a 3-hole into the abdomen, and the myomas are then removed. But when this procedure cannot be done, due to either the size of the fibroids or lack of facility, because not all hospitals can afford that.
Just a minute there. What is laparoscopic myomectomy? How is it done? Because when you talk of open myomectomy, someone can easily understand,
visualize,
open the abdomen and look into the uterus. But then what is that
laparoscopic myomectomy? Basically, we use cameras. So 3 holes are done on the abdomen of the woman, but this is done under anesthesia. So basically, she's knocked off. She does not feel a thing. We insert cameras and we visualize it on the TV that is placed in front of us.
Okay.
So we go and where the myomas are, and they're resected. So small scissors, small instruments are inside. Yes.
Oh, okay. Yes. And then open myomectomy.
Open myomectomy is whereby we use a blade. We cut open the abdomen again under anesthesia. So the woman is basically not aware. Okay. She's not awake for it. We go in through the 7 layers of the abdomen, reach the uterus, look for those fibroids, again cut and resect. The advantage of open myomectomy is where you can basically see the myomas and easily resect even the smallest ones out. With the laparoscopic myomectomy, sometimes you see mobility can be a little bit of a problem. If the woman has adhesions, that can also kind of limit your movement, and you might not be able to reach all the myomas as you had planned initially.
Yeah, we are still looking at infertility, and you talked of PCOS.
Yes.
Can we talk about management for PCOS?
Sure, definitely. You see, PCOS is a multidisciplinary thing. It needs a multidisciplinary action of things, because basically it causes gynecological problems, it causes dermatological problems, and metabolic. So if I just give you a short of what I mean.
Yes.
By dermatological, I mean about the hair growth, the acne, yeah. We also have darker skin patches on the neck, very visualized by naked eye, yeah. Then we have metabolic disturbances in the body. So basically, women who have PCOS are at a high risk of getting type 2 diabetic mellitus.
Okay.
Yes. Okay. Which in the long run, of course, you are also at risk of cardiovascular issues to the heart. Yes.
That's serious.
So is that serious? Yes. When I mention gynecological problems, I talk about menstrual problems. I talk about, when I say menstrual problems, you can have oligomenorrhea, which basically has less than 9 periods in a year. You can have irregular menses in the sense that she'll just come telling you that I get my periods, but they're very little. It's just spotting. Just basic spotting. Yes. Or someone else will come and tell you, I don't have a specific cycle. I might bleed 2 to 3 times in a month.
Oh.
Yes. Someone will even tell you, I'm amenorrhea. No bleeding at all for 6 to 8 months. Nothing.
Okay. That scares.
It is
for a woman in a reproductive age, and you're not
you don't see you bleeding. It is a little troublesome for them. And it's understandable, basically. You will not believe if I tell you that they also have sleep apnea. When I see sleep apnea, they have breathing difficulties, episodes of breathing difficulties during the sleep. So they wake up gasping for air. Or they just wake up. The whole night is a disturbed night for them. So imagine having continuous disturbed nights overnight, and then the exhaustion and the fatigue that kicks in the day, during the daytime. So they end up not being able to do their daily routine work because of that.
Does that mean PCOS has stages?
Stages, yes, but most of the time it's the symptoms that is bothering the woman. So the sleep apnea, I'm telling you, 80% of the women have sleep apnea. 45 to 80% are obese. They just don't realize, and they've put on so many kilos.
Just body keeps expanding.
The body keeps, and they have no clue as to what is going on
until they walk into a hospital.
Until they come to the hospital.
So they come to the hospital. And what do you do?
The majority of them will come for their period problems and infertility. These two are the things that actually bring them to the hospital. So when they do come to the hospital, we usually take their history, like I explained, and there are some lab works that we need to do. Now, ideally, in a normal woman, we have the follicle stimulating hormone and the luteinizing hormone, which works in phases. The follicle stimulating hormone is basically the ones that stimulates the follicles to reach the size required for ovulation. And that's where the luteinizing hormone kicks in, and the follicle is then ovulated. Now, in a polycystic woman, the follicle stimulating hormone is low. That means there is no stimulation of the follicles. So there is an ovulation, no ovulation that occurs. Okay, the luteinizing hormone is high all the time. So there is that. The whole ovulatory cycle is damaged, disturbed. Okay, then we have the insulin sensitivity that kicks in. So basically, the insulin is not sensitive. The cells are not sensitive. The insulin is not working with the cells well. So the glucose uptake is not done. That means there is free glucose that moves around, and the cells are not able to take it.
Consume it.
Yes. Okay. So what happens? You're at risk for type 2 diabetes.
So how do you manage?
Now, so when they come with all that, management depends on what their complaints are and the desire for pregnancy. So for those who come with hirsutism, the growth of hair, basically we check for their testosterone levels, because that is the androgen the male hormone, I would say. So usually if that is noted to be high, there are drugs that can be given, such as finasteride, spironolactone, over a period of time
to reduce the male hormone.
Yes, and it also helps with the hair growth.
The hair disappears.
Yes,
the acne
mostly,
disappears.
yeah, the hair disappears.
Okay.
The other tests that can be done are the follicle stimulating hormone and the luteinizing hormone, whereby we take the ratio and it gives us an idea of what we are dealing with. Other tests that are usually done, anti-Mullerian hormone, because we need to rule out premature ovarian failure before we go for diagnosing PCOS. We need to do, because these things, the PCOS have high glucose levels, so we need to be monitoring that, doing OGTT, oral glucose tolerance test, or fasting glucose levels. And then the cholesterol levels are basically high in PCOS women. Yeah, so we need to be doing the follow-up cholesterol levels as well. What is also very important is the levels of thyroid and prolactin as well. These get disturbed as well. Sometimes just a normal thyroid problem can cause irregular menses. So we need to draw the line of where we are standing. Are we dealing with PCOS or are we dealing with a thyroid?
Okay.
And sometimes we have an axis called hypothalamic pituitary adrenal axis, whereby the adrenocorticotropic hormone is high, that causes high, androgen levels in the body as well. So when that is disturbed, the thyroid levels are also disturbed. So those levels are also very important for us.
But they can be managed.
Yes, definitely they can be managed. Then another important test that we do is an ultrasound, be it a transvaginal ultrasound or a pelvic ultrasound. You basically visualize on the ovaries and you actually see the multiple cysts
surrounding the ovaries.
On the edges, yes, of the ovaries.
And what do you do to them? Now we are looking at how do you get rid of PCOS?
Well,
when it appears like that.
Yeah, when it appears like that, basically that's where the management kicks in. Yeah. So the woman comes in, like I said, for the hirsutism, you do that. You give the finasterides or the spironolactones. Sometimes combined oral contraceptive pills are also given. These are given for those women who have irregular cycles. They might bleed 2 to 3 times in a month. How do you regulate? You give them the contraceptive pills. But not only for that, COCs are also helpful as a contraceptive for those women who are not ready for a pregnancy at that time. So this is like a multi-action drug for them. Okay. Then metformin comes in. That's where the inflammation around the ovaries, the metformin not only helps with that, but metformin basically is used more for the insulin sensitivity. Yes. Then we have something known as ionositol or ovasitol. Those are ovary boosters. So they also help with ovulation. The cyst that we see, they prevent an egg or follicle from releasing, from ovulating. So these boosters, they help calm the inflammatory process around there, so that ovulation can take place. Yes.
Oh, yeah, quite interesting.
And we have ovulation induction drugs like letrozole and clomiphene. Like I said, they help stimulate so that a woman can conceive. But all in all, if all that fails, there is always IVF.
IVF, like you said previously.
Yes, previously. A good thing with IVF and PCOS, it's individualized. So the dose that is given, there is a close follow-up so that she does not get hyper-stimulated. Yes.
Okay.
And of course, taking all that into consideration, lifestyle modification is one of the most important things when it comes to PCOS. Lifestyle, when I talk about lifestyle, what we are doing here, the drugs, that is just 10% of the management. 70% of the management comes from dietary changes only.
So a woman who is presenting with PCOS, what should she eat?
We recommend a high protein diet, a high protein and fiber diet, cinnamon, and exercise. 20% of the management comes from exercise. So we need exercise it will not only help with the weight loss journey, but it also helps with the high cholesterol levels that we're talking about, insulin sensitivity. Exercise is very important to prevent further cardiovascular symptoms, further cardiovascular problems, and type 2 diabetes. So it's not only helping you manage your problem currently, but it is also a preventive thing for the future. And it prepares your body. If you're managing it well, even doing IVF, your chances of conceiving becomes high as well.
Oh, wonderful. These are interesting things the doctor is talking about. We are about to finish on the issue of infertility. We are just left with one segment called endometriosis. When we come back, we shall look at that. Don't go away. We'll be back, and I believe you're still there because I talked of endometriosis. You want to know what that is through the lenses of Dr. Shabnam. Doc, when we are beginning, you talked about very many issues, and one of them was endometriosis.
Yes.
What is that, and how can it be managed?
Okay, sure. I think I'll just give you an overview of what endometriosis is, yeah? Because it is something that we have commonly been seeing as well. And a lot of women suffer from that as well. So when we mention endometriosis, basically, in short terms, endometriosis happens when the linings, the cells of the uterus, get attached somewhere other than the uterus, basically.
Okay.
Yeah, so those cells go and attach either on the ovaries, on the small intestine, on the large intestine. Sometimes it can also attach on the lungs, as far as the lungs are concerned.
From the uterus to almost everywhere in the body.
Yes, so it can happen anywhere. Okay, when that happens, the tendency of those cells are to bleed, basically, a monthly cycle.
Those cells in the uterus?
Yeah, that's why women have a monthly cycle.
Okay.
So as that happens, the cells that have implanted elsewhere also tend to behave in the same way. Okay. The most common site, of course, being the ovaries. Yeah, so that's why we end up seeing chocolate cysts or cysts that form on the ovaries, and they're actually brownish in color. Hence the name chocolate cyst, because those cells tend to bleed as well.
So when a woman is menstruating, the cells that planted
also tend
in
to have that kind of tendency. Of course, not to a very big extent as the cells inside the uterus. Endometriosis is affecting a lot of women nowadays, and it is one of the major causes of infertility as well, because we don't know to what extent those cells then absorb the ovary, inhibiting ovulation as well to some extent. Again, with the when I say the cause is again unknown, but there are some I would say risks or some theories that have been evolved as to how it happens. One of the theory explains the drainage or the lymphatic drainage or the blood supply. That explains how the cells from the uterus can go into the lungs. Yeah, so that is through the lymphatic drainage or the vessels. The other theory basically happens where there is retrograde implantation. So the cells somehow from the uterus go through the tubes into the ovaries, and that is where they attach.
And they disorganize the follicle formulation.
Yes, it does, because imagine something that is not supposed to be there, and it is there, slowly growing over time.
So it disrupts the normal.
Definitely. It also impairs the ovarian reserve. Yes, with time. Another theory that has been noted to cause endometriosis is surgery. Most common cesarean sections that we do here. So if you're not careful, and surgery always has risks. So that is one of the theory that has been noted, that it could, while you're doing surgery, the cells could implant elsewhere. Yes.
Okay, so when you find a woman with endometriosis, what do you do to manage it?
Usually, majority of them come because of infertility or pain. Painful menstruation, either before or the pain just lasts. Pain is one of the most common symptoms. The other symptoms are painful intercourse, painful urination, painful defecation. But majority of the time, it's the infertility and the menstrual pain that brings them to the hospital. Now, of course, you need to find out why the pain is, why she's complaining of what is she is. So we do tests. Sometimes, majority of the times, we do the ultrasound. That gives us an idea of what we are dealing with. But of course, the mainstay of diagnosing is through a laparoscopy, and then they take the sample for biopsy as well. So histology is done as well. When we come to management, for the pain, we usually start with something known as non-steroidal anti-inflammatories. That helps to a great extent for the pain. But of course, the same laparoscopy can be done to excise the sites where the endometriotic cells have implanted. Yeah. Other surgical methods are open laparotomy, and they go and excise as much as possible. For women wanting pregnancy, natural conception becomes very difficult.
Almost impossible.
Yes, it becomes very difficult. So for them, the mainstay becomes in vitro fertilization, IVF. And before they opt for IVF, it is very important for them to do anti-Mullerian hormone to look at the ovarian reserve. Because in some cases, it becomes, they delay in coming in, and it's very important for us to know how many, what count are we dealing with. So anti-Mullerian hormone plays a major role in such women. And of course, if we have a woman that comes in, she's finished her family, she's had her children, something known as total abdominal hysterectomy
What's that?
can be advised, where the uterus is basically removed.
Just the uterus, and you leave the tubes and the she has no ovaries.
Yeah, so sometimes depending on what you see inside is what you remove. So we might leave one ovary behind, or we might come out with both of them. It all depends on what we see as you go in.
Okay.
Yes.
Wow. We are wrapping up on infertility, and in the beginning, you talked about an interesting point of most women come alone when there is no child in the home. So what message do you have for couples struggling? Just look straight into that camera and tell couples who are struggling with barrenness and those men who are not accompanying their women to the hospital.
Okay. My couples out there, my lovely people, if you've been struggling with infertility, if you've been looking for children, looking for a pregnancy, and after a period of time, you're not getting anything, please do not be afraid. Come to the hospital. Find out what is causing your infertility. And a lot of them have options available for such things. Options are there for you to have the biggest blessing in your life. And my beloved husbands, please accompany your wives, not only for finding the cause, but also for the moral support, for the strength, for the backbone that you can be for your wife. Because marriage is how it is. Support each other so that you can both enjoy the blissful parenthood. That's what I would tell them.
But we are still here with Dr. Shabnam discussing health issues affecting women. And one of the culprits is cervical cancer. She can tell us more about that, how it can be avoided, if it can be avoided, and how it can be managed. Doc, we are back.
Thank you.
Cervical cancer.
Okay, so basically, cervical cancer. What is cervical cancer? This is the cancer of the cervix. What is the cervix? It's the neck of the uterus. It's one of the topmost leading cancers in Tanzania. About 9,700 new cases are detected, and almost, I would say, 6,700 cases die because of cervical cancer
every
year in Tanzania.
Sad.
So it is the topmost, one of the first leading cancers in Tanzania, and a lot of women are suffering from it because they don't know that it can be prevented. One of the biggest culprit of cervical cancer is the HPV virus, the HPV, human papilloma virus. Now, human papilloma virus has a lot of strands. but the biggest culprits are the strand 16 and 18. These basically alter the cells. I will not go into the science and the medical term, but we have something known as the transformation zone in the cervix. Okay, so changes occur because of this HPV virus. Those changes, the dysplastic changes, whereby they alter the cells and turn them into dysplastic cells. Metaplasia occurs, dysplasia occurs, and precancerous lesions can then be formed. Okay, this can be definitely prevented.
Okay.
It is one of the cancers that can be routinely screened. And we usually recommend women of reproductive age who are sexually active to be having routine screening. Now, when I say routine screening, what do we screen for? There is a very popular test called the pap smear. I'm sure a lot of women have heard it, but many of them don't come and do them routinely. Some of them haven't even done it throughout their youth.
Or maybe they have not heard of it.
Or maybe they're not even educated on what a pap smear is. I wouldn't be surprised. Yeah, so something known as pap smear. Basically, we take cells from the cervix, and the same cells are then taken for testing for these precancerous lesions. While we do the pap test, we also do the HPV test as well, knowing that HPV is the one that is the leading cause responsible for it. So at the same time when we're taking the pap test, we take a sample for the HPV test, and they're sent for cytology and the diagnosing. There are the primary preventions as well, where we encourage women to stick to one partner, to be faithful to one another. Circumcision, one of the things that can help with primary prevention. Educating the women, educating the men. And nowadays we're lucky, we have vaccination. So vaccinate for little girls. Teenage gap from 14 to about 17. They are vaccinated.
Is it done in every hospital in Tanzania?
Yes, in fact, the government has provided vaccines to all the hospitals, be it private or government hospitals. The vaccines are free of charge.
So someone can walk in, for example, to Sally International and say, want HPV vaccination?
Yes, so the young girls are given those vaccines. That helps prevent this cancer in the long run. Okay, so routine screening also helps us with the pap test. Now, let's say if a woman has gotten the pap done and it comes back normal. So we encourage her to do a pap every 3 years. Every 3 years, do a pap smear. It is one thing that will help you detect early cancer. And the earlier it is detected, it is treatable. You eradicate it completely.
And you're safe.
And you're safe. In fact, even if you do get an early stage, you can prevent it into going into further stages.
Okay.
But unfortunately, women come in
when it's
at a
too
very late stage.
What do you think should be done for women to get to know about
We need to educate them. They need to be told that a very simple test can save their lives. A very simple vaccine can be given to young girls to protect them from the future.
What do you think is the best method of passing this communication? Should we do it on radio? Should we go to TV? Should we go to schools? Should we go to church?
In fact, I have seen hospitals and doctors actually visiting schools, doing seminars. Radio, you could have a small session, just 5-minute session. Doesn't even take long. Just educate people. I think nowadays even social media, even women have Facebooks. We have Instagram. Just keep posting about pap tests, keep posting about HPV tests, keep posting about cervical cancer, because it is one cancer that can be prevented. All those deaths can be prevented.
Oh, great. So men and women, our daughters, cervical cancer, as doctor says, is one of the most serious cancers, not only in Tanzania, but maybe on the continent. Share the information, tell people about it. Vaccines are for free, and we can combine efforts and eradicate this killer cancer in women. Don't go away. We are coming for the last topic, which is on antenatal care for the pregnant mothers. See you in a bit. We are back with our last topic of the day. Quite important one. Antenatal care. Doctor.
Yes.
Antenatal care. What's antenatal care and why is it important?
Basically, antenatal care is given to those women who are expecting. Okay? And usually it is done in those hospitals where she intends to deliver. Now, when we say antenatal care, what type of care do we give to the patients or to the clients or to the would-be mothers? There's a lot that is usually done in that visit. So basically we have cards like these, yeah?
Okay.
Each hospital has their own card. There is normal government cards that we have. We have the Sally Hospital cards here, which usually entails all the details of the patients that are needed. If there are any previous deliveries that were done, what were the outcomes, the blood grouping, the other blood workout, the urine workouts, and details of all your visits at the hospitals.
Okay.
Now, when a woman comes in, not only does she follow up with her pregnancies, but there is that bond that you create with your doctor.
Okay.
You get comfortable with the environment, you get comfortable with your doctor. It becomes easier for you to discuss the problems that you're going through during pregnancies. Sometimes your body undergoes a lot of changes, so sometimes the woman gets stressed out. The weight of the baby, the posture change. Just talking to your doctor about this relieves them.
Therapy.
It's therapy.
Wow.
It's therapy, you see. So we prefer talking to our clients. We prefer telling them that this is very natural for you to undergo. But we are here for you. We are here to provide you the counseling that you require.
How often should a pregnant mother come
Ideally,
for antenatal care?
If it is, we recommend them to start as soon as they find out they're pregnant. You start your clinics, okay? And then we recommend monthly visits for those pregnancies that are normal, no high risks. But for those with high-risk pregnancies, we recommend close follow-up, at least 2 weekly, depending on the situation. Okay? When they come for monthly visits, we do the blood workup, we do the blood pressure, we do the weight changes for the women because we expect a certain amount of weight gain per month. For the whole pregnancy, about 11 kilos.
Oh,
yes. Okay. So we have several checks that we do. The urine tests, to check for other things, to make sure that the woman is healthy, that the baby is growing well. So ultrasounds, hemoglobin levels, the protein in the urine infections, all that is basically done every visit as she comes.
Yes. There is some mama out there in the village. Maybe she does not understand about antenatal care. Maybe she has never gone for antenatal care. So for women who don't come for this care, what do they miss?
First of all, they miss the therapy the doctor can provide. They miss the basics checks. So a lot of those women are anemic. They have low blood levels and they're not aware. They end up giving birth to premature babies. They get complications during deliveries. Many of them do not have the facility to follow up with blood pressure checkups. So there is a condition where blood pressure shoots up in pregnant ladies, and it is very life-threatening to the mother and the baby as well. So these conditions go undetected. When they go undetected, the consequences are fatal. You can have fits, you can have death of the fetus in utero, you can have a premature baby, and so forth.
So it's something that every woman ought to do when they are pregnant.
Definitely. A follow-up at the hospital, not only hospital, be it a dispensary, health center, is very important. There are a lot of things that we follow up, and if you do that timely, a lot of things get detected early on, and intervention is done, and everything is settled.
And when it comes to feeding for pregnant mother,
of course, after We counsel them or we educate them as the time approaches delivery, how you need to hold your baby, what you need to do post delivery for the breast milk formation, and post delivery again. We don't just let them be. We have follow-ups
You keep
again.
following
Yes,
up
we follow up until we
until-
know that she is settled and the postpartum period is over. Again, postpartum period 40 to 42 days, right? So basically post that we counsel them on contraceptives as well, so that we give her time to bond with her baby and also for her body to recover before she is able to actually conceive again.
Okay, Doc, thank you so much for this
You're
sharing all
welcome.
this information. Now I'm requesting for your last word for a pregnant mother or for a girl who is there thinking about getting pregnant. What should they know? Look straight into that camera.
Anybody out there trying to get pregnant or thinking about getting pregnant, I wish you all the best, but I recommend please visit your doctor. Come with your spouse, come with your partner, because we encourage for you to be in this together. Partnership is 50-50. Come over so we can assist you into the smooth transition.
Thank you so
very
much, Doctor, for sharing this
Thank you so
very
much.
important information. See you next time.
Thank you very much. Good day.
Good day.